Hello, this is Marquel, and my topic for the week is thrombophilia and transient arrhythmioblastopenia of childhood. Thrombophilia is the unusual development of a clot comprised of blood components inside a vessel. It is produced as a consequence of a disturbance in the delicate balance among the anticoagulant, the proagulant, and the fibrinolytic system. The pathophysiology of thrombophilia is the abnormal formation of a clot composed of blood elements inside a vessel. It develops as a result of a disruption in the delicate balance between the procoagulant, the anticoagulant, and the fibrinolytic system. 3 changes happen during this time: changes in blood flow, changes in the vascular wall, and changes in blood vessels of coagulation factors and their inhibitors. Clinical manifestations. In the pediatric age group, thrombosis occurs most frequently before the age of 1 and in adolescence. There will be a history of blood clots. Depending on the area of the clot, for example, a blood clot that has formed in the heart will cause chest pain and shortness of breath and pain in the left arm that is severe. This disease will manifest itself depending on which organ system is affected. Diagnosis for thrombophilia includes Doppler studies, ultrasounds, echocardiograph, CT, and MRIs. Treating thrombophilia includes early diagnosis and sometimes replacement therapy. The goal in treating thrombophilia is to prevent enlargement of thrombosis, pulmonary, central nervous system, and other organ emboli. Children should be evaluated carefully and treated quickly. When pediatricians are encountered with patients with thrombosis, a family history should be carefully obtained. The risk should be shared with the family, and the best treatment approaches should be implemented for each patient. This can be accomplished by consulting centers that see more patients in this area, specifically hematologists and vascular specialists. Transient arrhythmioblastopenia of childhood, also known as TEC, is a type of pure red cell aplasia that is self-limiting and transpires in kids 4 years old and younger. Pathophysiology. The pathophysiology of TEC remains unclear. There could be a mutual connection with a virus-like illness that has suggested that TEC is triggered by virus-induced suppression of erythropoiesis, underlying genetic predisposition, and unknown environmental triggers also. TEC usually occurs in patients older than 6 months of age, specifically children that are between the ages of 1 and 4 years old. Boys are affected more often than girls. Signs of severe anemia, such as pallor, tiredness, anorexia, will cause most patients to seek medical attention. A history of viral illness indicated by symptoms 2 to 3 months before the development of TEC. A viral illness such as an upper respiratory tract infection and diarrhea. Physical exam findings are usually unremarkable except for signs of anemia. Diagnosis. An extensive workup is usually not required. If the MCV is normal and the blood smear does not insinuate an erythrocyte disorder or leukemia, then it's not necessary. In most cases, a CBC with diff peripheral blood smear, and reticulocyte count are appropriate to evaluate TEC. And then sometimes a bone marrow aspirate. Treatment for TEC. Spontaneous resolution of TEC occurs in 2 to 8 weeks without interventions. Observation is adequate in most situations, and erythrocyte transfusion is seldom needed except when there is hemodynamic instability or when TEC interferes with quality of life. Follow-up and referral. Follow-up and referrals are usually not indicated. The prognosis for TEC is excellent, and most patients recover in about 2 months.